very good afternoon to all, respected faculties, my dear seniors, and my dear colleagues. Today I'm here to discuss about acquired bleeding and coagulation disorders under the guidance of Dr. Akshay Kumar sir. So before we discuss this topic, this is going to be a very interactive session rather than a classical didactic presentation. So I would encourage you all to participate. So as you all have already worked in screening C, I think except the first semesters, majority have already worked. So I would like you to answer one by one what were the causes of bleeding that you have seen in the patients that were presenting to screening C. So starting with Jyoti Swarup sir, what are the causes and that the patient has presented most commonly? So one was CLD. Dr. Devansh. Yeah, I think very good. Dr. Rahul, anticoagulant related bleeding. Dr. Akhil, any trauma related bleeding. Dr. Vivek, so bone marrow disorders causing bleeding. Dr. Archana, coagulation disorder. Okay. So this is the most important aspect of my presentation as they have all listed out. One was CLD, the other one was platelet disorders, other one was coagulopathies and all. So in any bleeding patient, the first and foremost thing that one has to remember, that is the dictum, is securing the circulatory stability, which is the primary treatment priority in the bleeding patient. Let us first see this case. A 37-year-old female presents to emergency with complaints of bleeding from nose and mouth for the past 3 days. She has no prior comorbidities and denies taking any medication. She has had two similar episodes last month. So how will you approach the case? Dr. Sheena, could you please answer? Very good. That is a very important thing that to do because this patient is actively bleeding. Very good. So you will proceed with primary survey. So very good, sit down. Thank you. So we see that the patient has a patent airway with a normal speech, a respiratory rate of 20 per minute, a room air saturation of 97% with a normal work of breathing. She has a pulse rate of 138 beats per minute and a blood pressure of 100 by 68 and a capillary refill time which is less than 2 seconds. She was conscious oriented with a GCS of 15. So what do you infer? Dr. Radhika, could you answer from this primary survey? So basically, this patient was in compensated shock. As you can see, the patient has tachycardia, but her blood pressure was maintained. So on physical examination, you notice that she has a pinpoint flat non-blanching lesions on the bilateral lower legs, and she has hemorrhagic blisters in the mouth. So this patient, as Sheena said, was triaged red. A wide bore IV cannula was placed, and relevant blood samples was drawn, which shows that CBC parameters were taken where there was marked thrombocytopenia with a platelet count of 7,000, with other CBC parameters such as TLC and hemoglobin, which were within the normal limits. And LFT, RFT, and BBG were within the normal limits. Before we see what was the cause of thrombocytopenia in such a case, let us see the bleeding patient as a whole. As I have already said, and I would like to re-emphasize it again and again, securing the circulatory stability is the most important thing in a bleeding patient rather than trying to find a cause first. So the first and foremost important thing to answer is whether the bleeding is significant, because it is not only important to know the severity of the bleeding, uh, not only for the choice of therapy, but also the urgency of therapy, how rapidly you are going to resuscitate that patient. Bleeding leading to hemodynamic instability, bleeding that is severe enough to require blood transfusion, more than one site of bleeding, and more than 3 episodes of bleeding from a single site on separate occasions. So going back to our basics, we are going to review all the steps of hemostasis. So wherever there is an endothelial injury that occurs, the first step is the vasoconstriction. Because of So for the hemorrhagic shock, you are saying. So, so there is class 1, class 2, and class 3 and class 4. There is 15% of the blood loss in. Yes, sir. Deeply. So going back to the basics, we are going to review the steps of hemostasis. So the first step was arteriolar vasoconstriction that occurs because of the release of the endothelin from the damaged endothelium. This arteriolar vasoconstriction, what it does is it limits the amount of bleed to that particular site. The second step is primary hemostasis, where a platelet plug is formed, followed by secondary hemostasis, where fibrin deposition occurs, and ultimately leading to clot stabilization and clot dissolution. So let us take each and every step into with a close look. The first thing is primary hemostasis. As I have already said, platelets are exposed to subendothelial collagen and von Willebrand factor. With the help of GP1B9 receptors on the platelet surface, there is attachment of these receptors to the von Willebrand factor, which is the first step, which is the platelet adhesion. This is then followed by platelet activation. What happens in that is there is a conformational shape of change of shape, where it changes from disc shape to that of the sphere shape, exposing the GP2B3 receptors. Now, after this, there is something called as platelet aggregation. With the help of GP2B3 receptors, platelets aggregate to each other via fibrinogen. After this, there is a release of platelet granules, such as ADP, thromboxane A2, and calcium, which further helps in platelet aggregation. This forms the primary platelet plug. Now, in secondary hemostasis, what happens in vivo is that whenever there is a wound, there is a release of large amount of tissue factor. Now, this tissue factor binds with factor 7 and it can activate thrombin formation by two different pathways. The first thing is that tissue factor combines with factor 7 and activates factor 9. As you can see here, it activates factor 9. Now, tissue factor can also activate factor 10 directly, along with factor 7 directly, factor 10, and then ultimately forming thrombin. Now, after these two pathways have occurred, there can be a third pathway also, where the thrombin activates factor 11 first, followed by factor 9, then factor 10, and along with factor 10 and 5, the thrombin can activate itself. So basically, thrombin has a mechanism of activating itself also, ultimately leading to fibrin formation, fibrin deposition. So there is a fibrinolytic pathway where there is broken down of the fibrin which is formed. So plasminogen is converted to plasmin in the presence of tissue plasminogen activator and urokinase, and factor 11, 12 and kallikrein also facilitate this process. Plasmin then degrades the fibrin into fibrin degradation products. Now there are certain natural antifibrinolytics in our body. These are plasminogen activator inhibitors, alpha 2 antiplasmins, alpha 2 macroglobulin, and thrombin activatable fibrinolysis inhibitors. The importance of each and every one we'll be discussing in further diseases. So due to specific derangement in the hemostatic pathway, patient can present with different clinical manifestations, which helps us to differentiate whether the patient has a primary hemostatic disorder or the patient has a primary clotting factor disorder. So patient with a primary hemostatic disorder normally presents with superficial mucocutaneous bleeds, such as bleeding from mouth, nose, GIT, urinary tract, and menorrhagia, whereas clotting factor disorders usually present with deep tissue bleeds. Also, petechia and ecchymosis are more common in hemostatic defects, whereas in clotting factor disorders, these are uncommon, and usually if ecchymosis are present, these are usually large. Excessive bleeding after the minor cuts are seen in primary hemostatic defects, whereas in clotting factor disorder, the bleeding that occurs after the cuts or invasive procedure is actually delayed because the primary hemostasis is still intact in them. So these are the broad categories that we will be discussing today. Acquired bleeding disorders, which can be thrombocytopenia related or there can be coagulation related. After coagulation related, it could be because of the liver disease, renal disease, or DIC. So we'll take one thing at a time. The first thing is acquired thrombocytopenia. The definition of thrombocytopenia, uh, Dr. Ravi, when do you call it? Normally, we take a platelet count of less than 1.5 lakhs, actually. So we will be restricting ourselves to acquired causes of thrombocytopenia. They could be causes causing decreased platelet production, increased platelet destruction, platelet loss, or splenic sequestration. Causes of decreased platelet production are marrow infiltration uh, because of the tumors or infection, viral infections, drugs, radiation, vitamin B12 or folate deficiency. The cause of increased platelet destruction could then be divided into immune causes and non-immune causes. So immune causes, the most importantly, we have immune thrombocytopenia, which we'll be dealing in detail. And in non-immune causes, we have TTP, HUS, DIC, viral infections, and drugs. Platelet loss can occur because of the excessive hemorrhage, hemodialysis, extracorporeal circulation also. And splenic sequestration can occur in diseases like sickle cell disease and cirrhosis. Normally, spleen sequesters 30% of the platelets. But in these disorders, there is increased splenic sequestration to up to 90%. So one more thing to remember is that viral infections and drugs, they cause both decreased platelet production and also increased platelet destruction. These are the huge and exhausting list of drugs that can actually cause thrombocytopenia. And these were given internally, but there are much many to it, to this list. Broadly, you can remember it as anticoagulants like heparin, antiplatelet drugs like abscesimab, eptifibatide, and tirofiban, and anti-malarials like quinine and quinidine, anti-tubercular drugs like rifampicin. Let us now discuss the algorithm for thrombocytopenia evaluation. When a patient presents to you with a platelet count of less than 1.5 lakhs, we look at other parameters also in the CBC, which is hemoglobin and the TLC count. Because if these are abnormal, then the patient actually has a pancytopenia. So you go for a bone marrow examination or the other ancillary tests to determine the cause of pancytopenia. But if the hemoglobin and WBC count are normal, then go for a peripheral blood smear as given. So in the peripheral blood smear, if the platelets are clumped, redraw the sample in sodium citrate or heparin. This is because there could be platelet clumping in vitro, which occurs because of its reaction with anticoagulant. Also, if the peripheral blood smear shows that the patient RBC morphology is normal and the platelets are normal or increased in size, consider drug-induced thrombocytopenia, infection-induced thrombocytopenia, idiopathic ITP, and congenital thrombocytopenia, which we will be discussing. But if the peripheral blood smear shows fragmented RBCs, which is nothing but cystocytes, then think of microangiopathic hemolytic anemias like DIC and TTP. So first discussing with ITP, how many of you have heard other names of ITP? Dr. Pradiman, can you tell me other standard names that nomenclature that we use? Okay. And Dr. Dev Krishna? Yeah, very good. So we have something called as idiopathic thrombocytopenic purpura or immune thrombocytic purpura. Both of these names are now abandoned. We don't use it anymore because it is seen that idiopathic thrombocytopenic purpura is not idiopathic in most of the cases. There can be secondary causes also, and also not immune thrombocytic purpura also, because most of the patients of ITP may actually not have purpura. It can be primary or secondary, primary without any trigger and secondary with which is triggered. The incidence is equal in both males and females, and between 30 to 60 years, there is a female predominance. So what happens is that there is formation of autoantibodies to the platelet surface glycoproteins, as you can see, mainly to GP2B3. Now, once these platelets get opsonized, these are then sequestered into splenic macrophages, which are then proceeded for destruction by the macrophages. But it is seen that even after splenectomy, there is a recurrence of ITP in patients. Why is so? Because spleen is not the only site of destruction of these platelets. There are other sites also like lymph nodes and liver. According to the time elapsed since the diagnosis, ITP can be divided into newly diagnosed, which is less than 3 months, persistent between 3 to 12 months, chronic, which is more than 12 months. Why this classification is important is because as we'll see, the choice of therapy depends on the time since the diagnosis. So this is a very funny picture which depicts that the platelets are morphologically and structurally normal in ITP. So there is no morphological or structural defect that ITP patients have. So these are the causes of secondary ITP, which can be broadly divided into autoimmune syndromes, which could be secondary to autoantibody production because of the systemic disorders like antiphospholipid antibody syndrome, Evans syndrome, IBD, RASLE. Immunodeficiency syndromes like CVID, HIV, selective IgA deficiency. Infections, most commonly HCV, is very pertinent in causing thrombocytopenia. So one must remember the HCV as a cause of thrombocytopenia. The rest are CMV, EBV, H. pylori, VZV, and Zika virus. Lymphoid malignancies such as CLL lymphoma and other medications or vaccines. One of the most important thing that is coming up is also COVID-19 vaccine. There's something called as vaccine-induced thrombotic thrombocytopenia, which also leads to thrombocytopenia. Why do we discuss the cause of secondary ITP? Because the management of the underlying disorder in so usually we see a lot of CLD patients having HCV infection and HCV related CLD. So even that can present with this, and also systemic autoimmune disorders. Like there are a lot of patients of SLE who come with flare and all, so they can be thrombocytopenia in them. Uh, so then infections, other infections like mostly sir viral infection, but even sepsis and other underlying disorders can also. Yes, sir. Tuberculosis actually bacterial are less likely, so more than viral. So they have given that. So causes of thrombocytopenia you are saying. So causes of thrombocytopenia could be, as I have listed, sir, increased platelet destruction. Like there could be one of the causes is immune causes. Other non-immune causes is the patient presenting with DIC. DIC most commonly patient present with sepsis. Patients present. So DIC can be there. TTP, HUS patients can be there. There could be drug-related causes like I have enumerated. So these patients usually many patients take anticoagulants, antiplatelet drugs which we are prescribing. So So dengue presents with thrombocytopenia, malaria presents with thrombocytopenia, and other viral infections and tropical fevers. So management of the underlying disorder in secondary ITP can lead to normalize the platelet count. And what is the difference between the primary ITP presentation in adults versus children is that majority of the adults with primary ITP progress to chronic illness, whereas it is seen that majority of the children with primary ITP, which is two-thirds of the children, actually have a spontaneous resolution within 6 months of the diagnosis. The clinical manifestations of ITP are that the bleeding may occur in two-thirds of the patients, which is actually significant. It is a typical platelet type of bleeding. As we have discussed, it is skin or mucous membrane bleeding. There can be petechiae, dry or wet purpura, ecchymosis or epistaxis, which we'll see in a while. The risk of severe or critical hemorrhage is actually less in ITP patients, but it is seen that the risk of intracranial hemorrhage is around 1.4% and risk of non-ICH severe bleeding is 9.6%. We don't know the cause. Chronic illness. If the underlying disorder is treated, then the secondary ITP patient can revert back to normal platelet counts. So in the clinical manifestation, as we have seen, petechiae are pinpoint flat dark red lesions due to the extravasation of the RBCs from the capillaries. And most commonly, when you do a physical examination, try to focus on the lower limbs in these patients because petechiae are formed in the dependent areas like foot and ankle and not on the sole of the foot because the subcutaneous tissue prevents the vessels from bleeding. And also in the patients who are bedridden, these petechiae can be found in the presacral regions. So try to look for petechiae in these areas. Purpura are more than 2 mm, dark red purplish discoloration of skin and mucous membrane caused by the confluent petechiae. Ecchymosis are larger lesions, but they are also not palpable. And hematomas are accumulations of blood in the skin or deeper tissues, which are less likely in ITP patients, but they are raised and palpable. Now, the very important question to address in ITP patient is bleeding risk. Why? Because not all patients with ITP with a low platelet count require therapy. It is only patients with risk of bleeding actually require therapy. So predictors of clinically significant bleeding in ITP patients are degree of thrombocytopenia, which is the first and foremost thing. In Tintinelli, it is mentioned to be less than 20,000, whereas in up to date, it is mentioned to be less than 10,000. So, a patient with previous history of bleeding, use of NSAIDs, liver disease, or kidney disease, because there is underlying coagulopathy also associated, female sex, and chronic ITP. All of these are predictors of clinically significant bleeding in ITP patients. And at a similar platelet count, it is seen that patients with ITP may actually bleed less than the patients of other forms of thrombocytopenia, like aplastic anemia. So, a patient with a platelet count of 30,000 of both aplastic anemia and ITP, aplastic anemia people will be having a higher risk of bleed. Can anyone, Dr. Vinayak, can you tell the reason why? Very good. So basically, these platelets are structurally and morphologically normal. And apart from that, the autoantibodies that are formed are actually targeting the older platelets. So the younger platelets, which are rich in alpha granules, dense bodies, and lysosomal granules, are actually preserved. So they are hemostatically better able to control the bleed. Majority of the major bleeding is uncommon with platelet count of more than 50,000, and most fatal bleeding complications occur with the counts of less than 30,000 or 20,000. So how do we diagnose ITP? It is a diagnosis of exclusion where there is isolated thrombocytopenia without anemia or leukopenia and without another apparent cause of thrombocytopenia. And I have previously asked, the cutoff of thrombocytopenia that we normally take is less than 1.5 lakhs. But in ITP, we take the cutoff of thrombocytopenia as less than 1 lakh, which you have to remember. The diagnosis of ITP, so it cannot be made confirmed in the emergency department because since it's a diagnosis of exclusion. The lab investigations that are minimum to be performed are peripheral blood smear to look at the platelet morphology and also to look at other lineages, HIV and HCV testing for all patients. Additional investigation that can be done are coagulation studies, H. pylori testing, thyroid function testing, bone marrow examination, immunological studies to look for autoantibodies, and vitamin B12 and folate levels. Testing for antiplatelet antibodies are not recommended. Why? Because they have very low sensitivity. These antibodies are not actually not detected in almost 70% of the patients with ITP. And a bone marrow examination is not required to initiate therapy in ITP. It is only in patients who are refractory to ITP therapy actually require a bone marrow examination. So before starting a first line therapy in our ED, a bone marrow confirmation need not be sought. Yes, sir. Refractory. Yes, sir. ITP. So it's a diagnosis of exclusion. So there is no actually criteria which is given. So they have said that you have to rule out all the other secondary causes of ITP that are correctable. And then in the ED, that's why we cannot make a diagnosis. Yes, sir. Diagnosed ITP. So the differential diagnoses are drug-induced thrombocytopenia, which can be because of the immune or non-immune causes. DITP, which is drug-induced immune thrombocytopenia, which is clinically indistinguishable from ITP. It occurs 5 to 14 days after the exposure to a drug, and once the drug exposure has been removed, the platelet counts normalize. So a careful history should be sought not only for any prescribed medications, but also for herbal remedies, food, or beverages. And most commonly, the beverage is alcohol or quinine in drinking water, which comes with the brand name of Shrutis. So, and so that Uh, it's an quinine and tonic water beverage. Yes, sir. It contains quinine, ma'am. So So then there is heparin-induced thrombocytopenia, which will be a whole separate lecture. Then drug-induced thrombotic microangiopathy, which are similar in presentation to TTP and HUS. Then there are certain infections, as I have highlighted, and liver disease. Almost 70% of the patients with liver disease actually have thrombocytopenia. There could be other microangiopathic processes like TTP, HUS, and DITMA, hereditary thrombocytopenia, MDS, and the other acquired bone marrow disorders, and HELP syndrome in pregnancy. So the management of ITP, the treatment goal should be to treat or prevent significant bleeding and not to normalize the platelet counts. It has to be remembered that these ITP patients have a baseline platelet count of between 50,000 to 60,000. So we need not normalize the platelet counts. We have to only treat the bleeding in such patients, or we have to prevent the risk of bleeding. Before this, the importance is the severity of the bleeding. The first thing is the minor bleeding category, where the bleeding is not severe or critical. So let's see what is severe bleeding. A fall in hemoglobin by 2 gram per deciliter, or requiring a transfusion of more than 2 units. And a critical bleeding is bleeding into a critical anatomical site, causing a hemodynamic instability or respiratory compromise. In the in the critical anatomical site, they have mentioned intraspinal, intraocular, retroperitoneal, intramuscular, causing compartment syndrome and pericardial. This categorization was given in American Society of Hematology Clinical Practice Guideline. So, when an adult patient presents with ITP, whom to treat is a very important question to address. So, rapid clinical assessment has to be made to answer this question. The bleeding site is one of the most important things to note, because not only it helps in characterization of the bleeding, whether it is a platelet type of bleeding or a clotting factor defect of bleeding, but also it helps in prediction of severity of bleeding. There is a study which was done which showed that a wet purpura and a hematuria, these were the two important things that patient initially presented with, and later on progressed to develop a more serious bleeding. So these two are very important markers. Then a platelet count. So a marked decrease in platelet counts, as I have shown you, less than 10,000 or 20,000. These patients are very high risk of bleeding. Other bleeding risk factors and therapies that were effective for this individual previously, these patients are more likely to respond to those therapies first. How to treat is answered by the severity of the bleeding. So critical bleeding patients, the first and foremost thing is immediate treatment with the help of platelet transfusion, IVIG or glucocorticoids. Severe bleeding, you can have a trial of IVIG and glucocorticoids, and if the patient does not respond, then you can bridge over to platelet transfusion plus IVIG. And in the cases of minor bleeding, you have to treat and correct the underlying contributing factors. And then glucocorticoids or IVIG are plus minus. So these are the first line therapies of ITP. Platelet transfusion indicated in critical bleeding or an invasive procedure is planned on an urgent basis. The rise in the platelet count is immediate, but you have to remember that these rise in platelet counts are only transient, because there is ongoing platelet destruction that is occurring. So you might see that these ITP patients are actually not responding to your platelet transfusion, and they actually require every 6 to 8 hourly, which have to be transfused. So one FSS unit or 4 to 6 units of pooled platelets, which is 1 unit per 10 kg of body weight. The adverse reactions are any transfusion reaction or infection. IVIG in case of critical or severe bleeding, and the rise in platelet counts are actually within 1 to 3 days. And IVIG, when we give along with the platelet transfusion, it increases the patient response to platelet transfusion. So the increase in the platelet counts are actually more rapid when you add an IVIG therapy. This IVIG works by interference with the macrophage uptake of the autoantibody coated platelets. The efficacy of IVIG and glucocorticoids are similar, but it is said that the short-term remission is better with IVIG, whereas long-term remission is better with glucocorticoids. The dose is 1 gram per kg for 1 to 2 days. And since many patients require the IVIG therapy in ED, you have to remember that the most common side effect is headache, which is seen in 60% of the patients. Also, whenever the patient complains of headache, also think about intracranial hemorrhage as one of the underlying cause. So glucocorticoids in case of critical or severe bleeding, the rise in the platelet counts are delayed actually, usually 2 to 14 days. These act by increasing the apoptosis of the autoantibody producing lymphocyte and decrease in the phagocytic activity. Now we can use a IV steroid or we can use a oral steroid. So when we use a IV steroid, which is pulse dexamethasone therapy, where we give 40 mg IV OD for 4 days, and we stop it without tapering it. And in oral therapy, we give prednisolone, which is 1 mg per kg for 21 days, and then we taper. It is seen that with pulse dexamethasone therapy, the rise in the platelet counts were more rapid, although the overall efficacy was same with both IV and oral. The ADRs are similar to that of the glucocorticoids that we commonly see. So we only give the pulse dose and then we don't taper it. No need to taper it. So platelet transfusion indication in ITP with respect to platelet counts. If it is less than 10,000 to 20,000, prophylactically it has to be given to prevent bleeding. If it is less than 50,000, then give it when the patient is having active bleeding. When you have planned a diagnostic puncture, then give it when the platelet counts are between 20,000 to 50,000. And if the patient is placed on invasive procedure, less than 50,000 are the cutoffs. The second line therapies of ITP are splenectomy, rituximab, and thrombopoietin receptor agonists like eltrombopag and romiplostin. So criteria for second line therapies are when the diagnosis of ITP has to be confirmed, possible causes of secondary ITP are reviewed and treated, platelet counts of less than 20,000 or 30,000, or ongoing bleeding episodes which are refractory to glucocorticoids. So usually second line therapies are not started in ED. So we have, this is a very broad classification that we have given, that adults who present with ITP more than 3 months, you look at the duration of the ITP. If it is between 3 to 12 months, then you can treat with rituximab or TPO-RA agonists. If the duration is more than 12 months, then you can have an additional choice of splenectomy. And it is said that since splenectomy is an invasive procedure, it is good to wait for at least 12 months because these patients can also have spontaneous resolution. So the next most important disease that we will be discussing is coagulopathy in liver disease. Normally, liver synthesize both pro and anticoagulants, except von Willebrand factor, factor 8, and factor 13A subunit. Now, once there is a liver damage, what happens is there is decrease in both procoagulants and anticoagulants, leading to a state called as rebalanced coagulation. So there are both anti-hemostatic drivers and pro-hemostatic drivers, which is leading to a tug of war in a cirrhotic patient. So what happens is the anti-hemostatic drivers that are present in cirrhotic patients are thrombocytopenia, low coagulation factors, all except factor 8, which is important to remember, and low levels of antiplasmin, thrombin activatable fibrinolytic inhibitor, and high TPA. Whereas pro-hemostatic drivers are high von Willebrand factor, low ADAMTS13, low protein CS, antithrombin, high factor 8, and a low plasminogen. So thrombocytopenia in cirrhotic patient can be because of the splenic sequestration, decrease in the thrombopoietin production by the hepatocytes, because of the immune mechanism such as HCV, which can lead to platelet destruction, or it could be bone marrow suppression because of the alcoholism, which these patients have. But platelet number, remember, in a patient of cirrhosis is a poor predictor of the platelet function. This is because there are certain factors that can enhance the platelet function. As we have already seen, there is increase in von Willebrand factor and decrease in ADAMTS13, and there is also increase in the platelet adhesion factor, which is PAF. All these three can increase the platelet function despite the poor number. Also, there are certain places where there is impaired platelet function in these patients, because these patients can progress to HRS, where there is uremic platelet dysfunction, or these patients can have underlying sepsis on top of cirrhosis, which also leads to direct toxic injury to platelets. So there is an entity called as accelerated intravascular coagulation and fibrinolysis. It is a very newly recognized entity. It is defined as a state of clinically relevant hyperfibrinolysis resulting from cirrhosis. So how is it different from DIC? Because this is what we actually think of when we first hear the name as AICF. So these are the certain characteristic features. In DIC, the primary problem is excessive activation of coagulation with excessive thrombin generation. Whereas in AICF, the primary problem is excessive fibrinolysis. And why it occurs, I'll be discussing in the subsequent slides. In DIC is commonly seen and it has multiple precipitants, as we'll be discussing. AICF is relatively uncommon and it is seen in advanced or decompensated CLD. DIC can be diagnosed by routine coagulation tests, whereas AICF, there is no widely available test and TEG is relatively insensitive to test hyperfibrinolysis. DIC patients can present with both bleeding or thrombotic complication. And AICF patients, when you hear the name AICF, just remember one line that these patients present with intractable bleeding which fails to respond to usual therapy. In DIC, there is no role of tranexamic acid except in trauma-related DIC, which I'll tell you why. And in AICF, tranexamic acid is the used therapy. Sir, I'll be discussing in the. So it is seen in 5 to 10% of decompensated CLD. In one study, it was seen that it is seen in 30% of the patients with decompensated CLD. 30. So it is variable actually. So in patients who come with acute hepatic failure and decompensated CLD associated with other organ failure, it is seen that it is seen in 30%. But normal decompensated CLD without leading to morts, it is seen in 5 to 10%. So no, I'll tell you how to diagnose AICF also. So understanding the mechanism of AICF is important. As I have previously highlighted, it is a primary state of hyperfibrinolysis. So what happens is that the endothelium produces, the endothelium has a Weber pellide bodies which produces tissue plasminogen activator. And these tissue plasminogen activator are normally cleared by the liver. So because of the inability of the liver to clear TPA, there are increased levels of TPA. Now this TPA will bind to the plasminogen and activate plasminogen to plasmin. Now this plasmin will cause clot dissolution as we know. So there is increased plasmin generation. Also, there is decrease in the hepatic production of alpha-2 antiplasmin and thrombin activatable fibrinolysis inhibitor. Both of these will also increase the clot dissolution. Also, we have to remember that there is a synthesized. Yes, yes, sir. Yes, antifibrinolytics, sir. Natural antifibrinolytics. So since there is decrease, no, sir, antifibrinolytics. The antiplasmin, what happens is it is normally bound to plasmin in a bound state. But what happens is in the presence of tissue plasminogen activator, TPA cleaves the plasminogen from the alpha to antiplasmin. So there is activation of plasmin, which will bind to the fibrin clot. And both of these are proteins which are synthesized by the liver. So there is decreased hepatic clearance. So there is decreased hepatic clearance of tissue plasminogen activator, which leads to increased plasmin generation, and there is decrease of alpha-2 antiplasmin and TAFI, which is because of the decreased production, which leads to increased clot dissolution, basically increased fibrinolysis. Also, there is a pitfall here is that even plasminogen activator inhibitor is also cleared by the liver, but PAI levels overall decrease. Why is it so? This is because there is thrombocytopenia also, and 90% of the PAI is from the platelets. The clinical manifestations of AICF are intractable delayed bleeding following procedures such as or trauma, such as oozing from the line sites, which is one of the very important, and it is seen in almost 90% of the patients of AICF. Spontaneous bleeds can occur, such as intramuscular hematoma or mucocutaneous bleeding. Then there could be persistent GI bleeding due to portal gastropathy. A hallmark manifestation of AICF is gradual, persistent bleeding that fails to respond to usual therapy. And also you have to remember that most of the patients with AICF do not have bleeds that are immediately life-threatening, as these don't have a severe anatomic lesion as the cause of the bleeding. So it is an ICU diagnosis usually and not an ED diagnosis. I'll also tell you why. The diagnosis of AICF, there is no diagnostic criteria which can diagnose AICF, and there is no widely available test as we have already seen. Diagnosis is based on recognition of appropriate clinical and lab findings. The clinical findings are that these patients have advanced cirrhosis and they have intractable bleeding which fails to respond to usual therapy. So these patients are usually bedridden patients, critically ill, cirrhotic patients who have received multiple transfusions like PRBCs, platelets, cryopreservation, and fibrinogen, basically, but they haven't responded to any of those therapies. It is seen in around 5 to 10% of decompensated CLD, and in some studies, as I have previously highlighted, it is seen up to 30%. The lab findings are, which can give some idea whether the patient actually has an AICF, is a D-dimer level that is profoundly elevated. Because as I have discussed, it is the breakdown of fibrin, excessive fibrinolysis, that is causing AICF. And fibrinogen levels will be markedly reduced because fibrinogen is broken down. And factor VIII levels are usually increased, unlike in DIC. As I have said, all the clotting factors are synthesized from the liver except factor VIII, which is synthesized by the endothelial cells. In the treatment of AICF, yes, sir, yes, sir. So I'll be discussing tech also. If the patient is, yes, sir. So in such patient, you can send tag and you can also send DIC profile. Yes, sir. So, in the treatment of AICF, the first is restoration of the fibrinogen levels, and this can be done with the help of cryoprecipitate. For intractable bleeding, target a fibrinogen level more than 150 to 200 milligram deciliter. Tranexamic acid. The very important thing is that a loading dose of 1 gram IV followed by continuous infusion of 1 gram over 8 hours repeatedly has to be given. Have you heard this before? Exactly. So it's a crash two trial, which is also implicated in AICF. In refractory cases, higher dose of tranexamic acid, which is 200 mg per hour infusion, can also be given. But the risk of seizures are higher at higher doses. So do not combine it with medication that can decrease the seizure threshold. Also, after the bleeding has resolved, IV TXA can be converted to oral TXA. Now, not, yeah. So, yeah, that is a very good question, Pradiman. The thing is that you cannot actually diagnose AICF in the first go. The patient, you can send all the markers of coagulation, like you can send a DIC profile, you can send TEG in A-beta ICU, or you can send in lab medicine, and you can start him on the actual therapy that is actually indicated. Like you can start him on somatic infusion, you can start him on pandom infusion, you can start him on all the, you can resuscitate with the blood production, everything. If the patient does not respond to anything, then that is where you have to suspect. And by this time, the TEG results and everything will be coming also. So then,
physically you should find out what are the causes of the disease. Apart from elevation in the factor B4 levels, is there anything which can help in the diagnosis? And patient already, so any patient who is suffering from chronic liver disease is at a risk to develop sepsis also.
Yes, sir.
So those patients can develop DIC. So apart from that factor 8 level, is there any other factor which can be helpful?
So usually factor 13 also they have said, and von Willebrand factors also they have said. Von Willebrand factors levels are also increased in DIC, but they have said that these are markedly elevated in patients of AICF. There is a very slight difference, sir, but it is said.
So very few labs are there which can check these factors. That means factor 8 can be done.
Yes, sir.
The factor 13 was some level over. One milligram factor can be increased in DIC.
DIC also, but markedly elevated in AICF.
Factor 13, what is the lab test of that?
It's an individual factor assay
Don't
only.
say, no. In my opinion,
Ristocetin.
you can say that there is a test, all the PP, APTT, everything will be normal, even platelet count is normal, still the patient is bleeding. So then you should suspect factor 13 deficiency, and there is a test called a urea clot lysis test. So that will be positive in that.
So in this sort of cases, can we see the DSC profile again and if it is D-range, because most of the patients will be D-range, we won't have factor 8 levels, D-dimer level is there, fibro level is there, this will be increased more in most of the cases. Can we give a try of transaction just to that one matter? Can we give a try?
D-dimer will be increased.
Fibrinogen will be low.
Both the condition, in DIC as well as ICF.
So can we give a sort of transaction and by giving
Why
rapid
not? Why
transaction?
not? Why not? Even DIC pathophysiology initially will increase thrombosis. It's better on these so why not?
Yes, sir.
Thromboelastogram, role of thromboelastogram. Are you going to say about
Yes,
it?
sir. After this, I will listen. So this is a very quoted study in multiple times, which is a quoted case report. So Kodali et al. Has seen that in a patient who is refractory to many therapies in the ED, in a cirrhotic patient who has come with severe bleeding. So they have what they have done is they have done a lot of transfusions. Like they have done PRBC transfusion, FFP, cryoprecipitate. As you can see, multiple platelet transfusions, everything. So what ultimately on around day 6 they have sent for a D dimer levels, and initially also they have sent a fibrinogen level. So which was as you can see the fibrinogen level was very low up to almost day 5 day 6, and after the and these were the D dimer levels which were markedly elevated around 6 to 7 days because somehow they couldn't send it earlier, these D dimer levels. So when the tranexamic acid infusion was started, these D dimer levels have markedly reduced within a day or two of infusion, and these fibrinogen levels have started to increase. So coagulation management during actively bleeding in a cirrhotic patient, what to transfuse and what not to transfuse, because there is a rebalanced coagulation which occurs. So the first thing is the platelet transfusion. A platelet transfusion has to be done in an actively bleeding cirrhotic patient when the platelet counts are less than 50,000. And the contraindications are known hypersensitivity and with a dose of 1 unit per 10 kg of the body weight. FFP transfusion has to be done whenever you have an evidence of prolonged R time on TEG, which is more than 10 minutes. And if it is unavailable, you can go for INR levels, but it is usually not recommended. We will discuss about what is prolonged R time. It is the time to start fibrin clot formation. Also, the contraindication to FFP is hypervolemia because these patients are already in a state of third space loss. So they are already fluid overload. So the dose is 10 to 15 ml per kg IV every 12 hourly. Cryoprecipitate is only recommended when the fibrinogen levels are less than 80 to 100 milligram per deciliter. And one has to remember that 1 unit per 10 kg of body weight we have to give similar to that of the platelets. And each unit of cryoprecipitate contains 200 mg of fibrinogen and 100 units of factor 8 per unit. Other therapies that we can be tried are plasmapheresis, which acts as a bridge to liver transplantation, and it can be producing good response in acute hepatic failure patients. Again, the contraindications are hypervolemia and hemodynamic instability. It is a single session and exchange of 30 to 50 ml per kg of plasma is done. Also, not all cirrhotic patients require vitamin K therapy. patients of liver disease who have underlying cholestasis, who are malnourished because of the underlying alcoholism or because of the nutrition itself, or patients who have undergone antibiotic therapy. So the dose is very important, that it is seen that in the cirrhotic patient, it is 10 mg per day, IV slow over 20 to 30 minutes for 3 days. We have seen here that in red areas, most of the patients have been receiving vitamin K like almost for a week or 2 weeks. This is not done, and also there is no indication of subcutaneous vitamin K in cirrhotic patients because of the uh, erratic bioavailability. Also, till now we have seen about bleeding in cirrhotic patients. So what about anticoagulants in cirrhotic patients? What is their coagulation hypercoagulable state? What is their state of hypercoagulability? Since patients with cirrhosis have an elevated INR, they are auto-anticoagulated. How many of you agree to the statement? Please raise your hands. So, which is very good to know that none of the people can fall into the pitfall because it is wrong. It is a misconception. So, whether to give or not, there are certain indications. So, overall, the current consensus is that in patients with cirrhosis, the hemostasis is shifted towards a procoagulant state. So a DVT prophylaxis should be given to all critically ill cirrhotic patients except in the following situation: active bleeding, severe thrombocytopenia, uncontrolled hyperfibrinolysis, and a TEG showing a pathologically prolonged R time. Remember that elevated INR doesn't reveal anything about coagulation, and it shouldn't be a contraindication to anticoagulation in cirrhotic patients. So one of the most important topics of discussion is thromboelastography, although I'll be discussing in very brief about TEG. So TEG is a viscoelastic hemostatic assay that measures the global viscoelastic properties of the whole blood clot formation under the low shear stress. It measures the development dynamics of clot development, clot stabilization of strength, and clot dissolution. So it is basically a graphical representation of the movement of a small pin which is suspended in a cup of whole blood. So as the blood starts to form, a clot, there is the movement of the pin increases, and this has been projected into a graph. As we can see, this is the cup and the pin. So So why TEG and not INR? This is because TEG will tell about both the status of coagulation and anticoagulation in the cirrhotic patient. So overall balance of the enzymatic coagulation can be told about in a cirrhotic patient. And INR does not predict any bleeding risk as I've previously highlighted. But since INR can be raised because of the deficiency of the clotting factors, vitamin K dependent clotting factors, which tells about the synthetic function of the liver. So it is used as a synthetic marker, prognostic marker. Also, TEG reduces the utilization of the blood products because we usually transfuse patients on the basis of INR. So therapy guided by TEG and not INR in patients with liver disease. Only prognostic scoring only. It is not for predicting the bleeding risk. So in thromboelastography, this is the graph that is obtained, and it has certain components: the R time, K time, alpha angle, maximum amplitude, and lysis at 30 minutes. The R time is the time to start forming a clot, and the normal value is between 5 to 10 minutes. And the problem with coagulation factors can lead to a delayed R time. In the K time, the time until the clot reaches a fixed strength is the K time, and the normal value is between 1 to 3 minutes. And the problem with fibrinogen can cause a delay in the K time. The alpha angle is the speed with which the fibrin is accumulated. And the normal values are 53 to 72 degrees. And the problem with fibrinogen can decrease the alpha angle. Also, maximum amplitude is the highest vertical amplitude of the text, as you can see here. It is usually 50 to 70 mm, and the platelet dysfunction can lead to a decrease in the maximum amplitude. Lysis at 30 minutes is the percentage of the amplitude reduction 30 minutes after the maximum amplitude has been achieved. And there is something called as lysis, LY60 also. So the normal value of LY30 is 0 to 8%, whereas that of LY60 is 15%. So this depicts the excess fibrinolysis. So tag interpretation, I would like Dr. Pradivan to answer this question. A 14-year-old, can you please read this for me? So the first of all, I would like you to answer which type of bleeding do you think on the basis of the physical examination? Very good. Okay. So this is the tech graph that you have got. The red lines depict that the it is a normal interpretation, and the black line is what you. Very good. And another parameter. Very good. So decrease alpha. You can sit down. Thank you. So there is a decreased maximum amplitude and low alpha angle, which shows that the patient has an underlying platelet dysfunction. Or so there is a decrease in the maximum amplitude, and there is also a decrease in the alpha angle. So there is a problem with the platelet dysfunction, or there is thrombocytopenia. And the treatment that is based on TEG is either platelet transfusion or DDAVP, which can cause a release of VWF from the endothelium and increase the platelet aggregation. And probable diagnosis from this picture appears to be ITP, although it has to be confirmed. Various patterns on TEG are, this is a normal, the first graph that you can see is normal. Normal R time, K time, maximum amplitude, and angle. Whenever, no, maximum amplitude is produced by the platelets or DDAP if there is low levels of desmopressin intrinsically. Alpha angle and alpha angle. Yes. Yes. So this is the R time. So R time is the time to start forming the clot, and the normal value is 5 to 10 minutes. And the problem is with coagulation factors. In the K time, the time until the clot reaches the fixed strength. Since fibrinogen comes in the later part of the coagulation pathway, so it is a primary fibrinogen deficiency that will cause a prolongation in the K time. Alpha angle is the speed of fibrin accumulation. So if there is a deficiency of fibrinogen, the speed with which the clot forms is also decreased. So the normal it is 53 to 72 degrees, but you can interpret it when there is a normal graph which is given for comparison. The maximum amplitude is the highest vertical amplitude of the tag, which is no, so not all we get. Com- Normal values are given, but the usually normal graph is not given in all the cases. So lysis at 30 minutes. So the percentage of the decrease in the amplitude, as you can see, almost about after 30 minutes, the amplitude is decreased. This decrease in amplitude should be at least between 0 to 8% from that of the maximum amplitude. If this amplitude is decreasing much more than that, that means there is excessive fibrinolysis, as we have seen in AICF. That's no
ट्रेन
time.
की तरह चले जा रहे हो समझ रहे हो बाकी अच्छा था तुम्हारा प्रेजेंटेशन ठीक है ना गाड़ी से आपको फीडबैक यही है अभी मैं बोलना जरूरी है थोड़ा सा स्पीड कम रखो बिकॉज द क्रिटिकल मूवमेंट इज दिस वन टैग वन ऐसे लोग याद नहीं करे भी तो चलेगा है ना बट टैग आम एवरी डे यू विल बी गोइंग टू यूज इट है ना तो इसमें आप थोड़ा सा अच्छी तरह बताओ ठीक है
So these are the various patterns on TEG. This is the normal pattern that we have seen. When the patients are on anticoagulants or having a hemophilia, basically clotting factor deficiency, as we have seen, R time and K time can be prolonged. And the maximum amplitude and the angle can be decreased in such patients, since it can be because of the fibrinogen deficiency also. And in platelet disorders like thrombocytopenia, thrombocytopathy, the R time can be normal, K time can be prolonged, and maximum amplitude is decreased. This is because the fibrinogen that is available is also not able to act. So there is no platelet aggregation. If the primary platelet plug is not formed, there is difficulty in forming the secondary platelet plug also. That's why the K time is prolonged. In fibrinolysis, there is presence of tissue plasma activator that we have seen, which causes hyperfibrinolysis. The R time is normal in that. So the clotting factors are actually normal in this. The maximum amplitude, there is a continuous decrease in the maximum amplitude. And the L by 30, since there is hyperfibrinolysis, as you can see, the maximum amplitude that was achieved was this. But within 30 minutes only, it has decreased to more than 8% definitely. It is almost more than 50% it has decreased. And LY60 also, more than 15% decrease should be there. hypercoagulation, what happens is the R time and K time are actually decreased, and the maximum amplitude and alpha angle are increased, as you can see here. In DIC stage 1, which is a hypercoagulable state with secondary fibrillation, the graph is almost similar. We'll be discussing it later on when we'll discuss DIC. And in stage 2, which is the hypocoagulable state, there is a prolongation of R time, K time, decrease in the maximum amplitude. Basically, everything in the coagulation pathway gets affected in DIC. So the next topic is bleeding and renal disease. There is not a specific level of BUN or serum creatinine above which the bleeding risk is increased and below which it is not. So do not correlate bleeding risk in a uremic patient according to the BUN or creat levels. The pathophysiology are platelet dysfunction plus abnormal platelet vessel wall interaction. So the intrinsic defects that occur are abnormal expression of the platelet glycoproteins, which will impair the platelet aggregation, altered release of the ADP and serotonin, decrease in the platelet thromboxane A2 generation, and abnormal platelet cytoskeletal assembly. The extrinsic factors are action of the uremic toxins, anemia, and increased nitric oxide production. It was seen that in a study that uremic platelets, when mixed with normal plasma, they had a normal function of the platelets, whereas normal platelets, when mixed with uremic plasma, had an abnormal function of the platelets. So it is all about uremic plasma. So the extrinsic defects are the most important in a patient with renal disease rather than intrinsic defects. So this is the pathogenesis of platelet dysfunction in patients with renal disease. The uremic toxins are guanidine and succinic acid and methylguanidine, which are precursors of nitric oxide production because they increase the CGMP levels. Now, this increase in nitric oxide production acts as inhibitor of platelet aggregation. So, this leads to decreased platelet aggregation. Now, in anemia, now in normal patient, what happens is that in a bloodstream, the RBCs are centrally located, whereas platelets are peripherally located. But in uremic patients, when the hematocrit is less than 30%, the RBCs are, the platelets are also centrally located. This leads to increased distance from the endothelial lining, which leads to decreased adhesion of the platelets. And this anemia acts as a rheological factor. Also, there is increased nitric oxide production, as I've said. There is uremic plasma, like these uremic toxins. These are only two of many actually stimulate the platelets and endothelium to release nitric oxide, and they themselves also act as precursors of nitric oxide production, so ultimately leading to decreased platelet aggregation. So therapeutic implications is that estrogen in the treatment of uremic bleed act by reducing the nitric oxide production. Treatment options are dialysis, which is recommended in uremic patients with active bleeding or who are in need of invasive procedures. The second therapy that you can initiate is desmopressin, IV or subcutaneous at a dose of 0.3 microgram per kg in 50 ml NS over 15-30 minutes if it is given IV. And when it is used for the prevention of bleeding, it is administered 30 to 60 minutes before the procedure. Correction of anemia with the help of PRBC transfusion or erythropoietin analogs. And estrogen, for a more chronic control, we can use conjugated estrogens can be used. So the next most important topic of today's discussion is disseminated intravascular coagulation. It is also known by the name of consumptive coagulopathy and defibrillation syndrome. It is a systemic process with the potential to cause thrombosis and hemorrhage, both. It can be presented as acute life-threatening emergency, where it is called as acute DIC, or it can be a chronic subclinical process in certain patients, leading to when it is called as chronic DIC. So this is what the overall picture of DIC, where there is an underlying precipitate. Now this underlying condition, whatever it is, as we'll be discussing, this underlying condition causes a release of lot of tissue factor. Now this tissue factor causes activation of intravascular coagulation. This intravascular coagulation leads to fibrin deposition. Now fibrin actually has a platelet and a fibrin component to it. So there is, because of the increased platelet consumption, there is decreased platelets. Because of increased coagulation factor consumption, the overall APTT are getting deranged and the overall factors are deficient. There is also fibrinolysis that occurs. I'll be discussing why the fibrinolysis occurs in DIC patients. This leads to increased D-dimer and increased FDPs. Also remember that both of these, increased D-dimers and increased FDPs, also interact with platelets and the fibrin and inhibit the platelet aggregation and also inhibit the fibrin clot formation. This leads to impaired coagulation and bleeding. Also, there is certain neutrophil activation which is seen in DIC patients. And it is seen that in the recent studies, it is seen that this is the most important cause of microvascular thrombosis in patients with DIC. So what happens is that in patients with DIC like sepsis or underlying cancer, there is a lot of release of cellular free DNAs, histones, and all these negatively charged particles. Now, these are released from the dead or dying neutrophils. These are extravascular chromatin. They trap all the procoagulant factors and they stimulate, leading to microvascular thrombosis. Also, there is endothelial activation or damage, which will directly lead to microvascular thrombosis. Now, this once the thrombin clot is formed, it can lead to microangiopathic hemolytic anemias, after which you can see cystocytes on the peripheral blood smear. So, there is both risk of bleeding and both risk of organ ischemia or organ failure in DIC patients. So, this is the pathophysiological classification of DIC. The first entity is the suppressed fibrinolytic type. We have taken an example of sepsis patient where there is release of LPS and cytokines. Now, both of these stimulate monocytes and macrophages to cause release of the tissue factor. And there is also decreased expression of the thrombomodulin. This is also because of the LPS and cytokines. Both of these cause activation of the coagulation. Also, what happens is these LPS and cytokines stimulate the endothelium to cause overexpression of the plasminogen activator inhibitor. This leads to decreased fibrinolysis. So there is overall activation of coagulation and inhibition of the fibrinolysis also, leading to multiple microthrombi causing multi-organ failure. This is the major mechanism in sepsis patients. So it is not a common notion that sepsis leading to DIC will only present with bleeding. The most common presentation of sepsis leading to DIC is actually a prothrombotic state in the form of multi-organ failure. In patients with enhanced fibrinolytic DIC, the leukemic cells usually release the tissue factor, and this happens usually after a chemotherapy session. There is activation of the coagulation, and also there is low expression of the plasminogen activator inhibitor. This is because uh, these leukemic cells also decrease the expression of these PAI molecules on the endothelium. This leads to dissolution of the large microthrombi which are formed. So the activation of coagulation, although it is occurring, but the hyperfibrinolysis which is occurring is the major component, leading to severe bleeding in such patients. Now, this enhanced fibrinolytic type is seen in certain leukemic conditions such as APML. So APML M3 usually presents with DIC. This is because the leukemic cells have OR rods in it, and these APML cells, and which are procoagulant in nature. Also, in balanced fibrinolytic type, what happens in certain cancer situations with solid organ tumors, there are ovarian cancers or pancreatic cancers, which are mucinous adenocarcinomas. There occurs activation of the coagulation, but the fibrinolysis is normal in them. So there is a balance that is maintained. So these patients most commonly present as asymptomatic or they present with minor bleeding. So also remember that one exception to this is the prostate cancer. Prostate cancer presents with enhanced fibrinolytic type of DIC. So these are the precipitants of DIC. Infections are the most common cause of DIC that we have to remember. Carcinoma, as I have previously noted, it is mostly adenocarcinomas of the ovarian, pancreas, gastric, and prostate cancer also. And most of the carcinomas present with chronic and compensated form of DIC. Acute leukemia, such as APML, usually present with enhanced fibrinolytic type of DIC. Trauma, especially brain injury. It was seen that trauma-related DIC occurs in almost, I'm forgetting the percentage, I think it is 35% of the brain injury related DIC patients. Organ injury, which is seen in liver disease and acute pancreatitis. In pregnancy, there can be placental abruption, amniotic fluid embolism, IUFD, and HELLP. These patients also present actually with enhanced fibrinolytic type of DIC, so basically presenting with bleeding. Vascular disease like large aortic aneurysms and hemangiomas. Both of these also present with enhanced fibrinolytic type. Snake bite, such as hemotoxic snake bites, like viperine bites and rattlesnakes. Acute lung injury. There is a very classical presentation, which is that 20% of the patients with acute lung injury develop DIC, and 20% of the patients of DIC actually develop acute lung injury during the course of their disease. So it can also be because of the acute hemolytic transfusion reaction. So these are the clinical manifestations of DIC. Whenever I call DIC in the emergency setting, it is usually an acute DIC. And the most common presentation of acute DIC is actually bleeding. This is because when the DIC develops so rapidly, the compensation of the synthesis of the coagulation factors from the liver, the compensation of the synthesis of the coagulation factors from the liver is not achievable. So in patients with chronic DIC, because of the compensation, they are in a balanced state and they do not actually present with bleeding. Renal dysfunction followed by hepatic dysfunction, respiratory dysfunction, shock, and thromboembolism. So also remember that acute DIC patients not only present with bleeding, but they can also present with thromboembolism. It is very rare that they only present with thrombosis. So CNS involvement can also be seen in 2% of the patients. Thrombosis is more common in chronic DIC, as I have stated that because of the compensation by the liver. So when to suspect DIC? In a patient with generalized oozing from multiple catheter sites or other signs of bleeding, or in a patient with unexplained thrombosis, along with the most importantly, underlying precipitant. There has to be an always underlying precipitant when you call it DIC. Because without the precipitant, the entire pathway of the coagulation cascade and hyperfibrinolysis do not occur in DIC. So these are the lab parameters that get deranged in DIC. In acute decompensated DIC, as you can see, because of the consumption of the platelet and the clotting factors, platelet count is reduced, PT, APTT are prolonged, thrombin time is also prolonged. Because of the consumption of fibrinogen, it is also reduced. Factor 5 is also reduced. Factor 8 is reduced, which is to be differentiated from AICF. And FDPs are elevated and D-dimer are elevated, which are also seen in AICF, but D-dimer are markedly elevated in them. In chronic compensated DIC, the most important thing is that the coagulation markers are normal, whereas hyperfibrinolysis markers can be elevated. So this is the contrast. This is because the liver is able to compensate for the uh, coagulation factors that are consumed in the hypercoagulation. This is peripheral blood picture in DIC, where you can see that these are helmet cells or cystocytes because of the microangiopathic hemolytic anemia. There is a Dr. Vinayak, can you answer a question? In patients with these microangiopathic hemolytic anemias, also they have microthrombi, like in TTP and HUS, disseminated microthrombi. So how are those microthrombi different from that of the DIC? Very good. So basically in DIC, there is the thrombi that are formed. They are basically of the fibrin clot. Whereas in the TTP and HUS, the clot that is formed are the platelet rich. So coagulation factors will be normal in TTP and HUS, whereas in DIC, the lab parameter as we have discussed, it is since it is fibrin rich, there will be defect in both coagulation factors and platelets. So the diagnostic confirmation of DIC is based on clinical and lab diagnosis. On basis of clinical diagnosis, it is the bleeding and thrombosis. And in lab diagnosis, it is evidence of thrombocytopenia, coagulation factor consumption, and fibrinolysis, which is increased D-dimer and FDPs. So DIC can commonly be diagnosed from our reading. But the pitfall is that it has to be in the presence of underlying precipitant. And also, no single lab test can confirm or eliminate the diagnosis. It is the amalgamation of all. This is the scoring that is given in DIC. It is the International Society on Thrombosis and Hemostasis scoring, which is used in patients of DIC when an underlying precipitant is known. So it has 4 markers, starting from that of the platelets. The first marker is that of the platelet. When a platelet count of more than 1 lakh, it is given a score of 0. 50,000 to 1 lakh, it is given a score of 1. Less than 50,000, it is given a score of 2. And then followed by clotting factors. Come to PT prolongation. Less than 3 seconds is given a score of 0. 3 to 6 is given a score of 1. And more than 6 is given a score of 2. After this, we can come to fibrinogen level. So I'm progressing from primary hemostasis to the clot dissolution, so that you can remember it well. So fibrinogen levels of more than 100 is given a score of 0, and fibrinogen levels of less than 100 is given a score of 1. And fibrinogen markers such as D-dimer, FDPs, they can be normal, mildly elevated, or markedly elevated, which is given a score of 0, 2, and 3. So a total score is that of 12, and it is called as overt DIC when it is more than equal to 5. Now, overt DIC, it is seen that there is increased risk of mortality. This is to predict the mortality risk in patients with DIC. Yes, sir. So chronic compensated DIC is also called as subclinical DIC only because the patient is actually in DIC, but because of the chronic compensation, he's actually asymptomatic and not presenting with bleeding or thrombosis, thrombotic manifestations as such. Only hyperpigmentosus markers will be D-dimer and FDP will be elevated, but coagulation factors will be normal. So it is seen that 20% of the patients with gram-negative sepsis have DIC. In the rest of the sepsis, it is actually variable, sir. So usually we send a DIC profile here, and which is easily available in the lab medicine. And whenever we see for the uh, bleeding risk in such patients, so
Said that the septic patients intubated patients start developing hydrated lesions, vulvar basically ecchymosis,
bleeding from ET tube and
in the
so not routinely we I think send, but
May not be overt bleeding. Overt bleeding more than that is the thing. So because you said the association is 20%, so which is a very significant number.
so routinely it should be sent DIC profile
Patient with
sepsis.
after how much time of the precipitant the DIC will develop?
There is no strict timeline which is given actually, so I don't think there is a specific time after which. Yes, sir.
Unless until there is enough evidence that clinical evidence that patient is either thrombotic or patient is having increased kidney, even if we are sending the DIC profile, it will not help in the management.
no, no, absolutely. What I am not talking about that, I'm saying that if you have a screening baseline,
So
then
we can anticipate in
absolutely,
advance.
Anticipate
absolutely,
bleeding.
that this patient is high risk for going into DIC. No? So you'll be better informed when you manage in the next shift person. देखो यार इसको इतना elevated है, keep it close
Might
watch on
bleed.
it. ठीक है ना? And
So, in the management of DIC, the first and the foremost is to treat the underlying cause to eliminate the stimulus for ongoing coagulation and thrombosis. And the supportive measures have to be taken part before doing a definitive management. So, which is hemodynamic and ventilatory support, aggressive hydration for acute hemolytic transfusion reaction, and RBC transfusion for severe bleeding. Also, for the prevention or treatment of bleeding, there can be platelet transfusion that can be done when the patient is actively bleeding with a, platelet count of less than 50,000. And the dose is again the same as we have seen. And if the patient is not actively bleeding, here the cutoff which is given for prophylactic platelet transfusion is less than 10,000. And in the patients who require FFP or cryoprecipitate transfusions are those in patients who are bleeding with a prolonged PT and APTT. If such in such a case, look for plasma fibrinogen levels. If it is less than 100, go for cryoprecipitate because cryoprecipitate has a very small volume, which is just 10 to 20 ml volume, but it has a very high volume of fibrinogen and factor 8. So as I have previously mentioned, 1 unit of cryoprecipitate contains 200 mg of fibrinogen and 100 units of factor 8. And if it is more than 100 milligram per deciliter, then go for FFP transfusion. The goal is to reduce the bleeding and not to normalize the coagulation test in patients with DIC. So, what not to use for the treatment of bleeding in DIC? Till now, we have discussed what can be used. So, antifibrinolytic agents and prothrombin complex concentrates are both contraindicated in DIC because they reflexly increase the risk of venous thromboembolic episodes in acute DIC patients. But there are certain conditions in which antifibrinolytic agents can be used, such as trauma-induced DIC, APML, and all the causes which cause the hyperfibrinolytic, enhanced fibrinolytic type of DIC. So why does trauma-induced DIC has a benefit of giving a tranexamic acid? Can anybody tell this? Dr.
Archana,
Jyoti sir.
Archana,
So if you can help us identify DIC, one thing is then there is endothelin activation and the function is there. But most importantly, this is hyperfibrinolysis is predominant. So that is what has stated.
Is it something related with autohypertension in people with trauma?
So it is said that what happens is in trauma patients is that they usually present with hemorrhagic shock, which leads to tissue hypoxia and a lot of acidosis and hypothermia and all these factors, which lead to massive release of tissue factor at once from the endothelium. But also it is said that the plasminogen activator inhibitor is actually produced by the liver, and it takes a very longer time for these levels to be elevated. So that's why tranexamic acid has a very good role in the first 8 hours of the trauma-related DIC, because in the first 8 hours the tissue factor levels are very high but PAI are very low. But in the next 8 hours the tranexamic acid should not be given. That is because it can reflexively increase the venous thromboembolic episodes, because now the PAI levels will also start to increase. So tranexamic acid is served as a double-edged sword, and it is seen that administration of yes. Okay.
Both in crash 2 was related to hemorrhagic shock, crash 3 was related to
Head
head
injury.
injury. And you yourself said in one slide that in trauma, if you have brain injury,
Brain injury.
there will increase
Almost 35, I think. So administration of tranexamic acid can be given along with heparins in enhanced fibrinolytic type of DIC. So prevention or treatment of thrombosis and DIC, for which we can use heparins, and it can only be used in case of life or limb threatening thrombosis, which is usually digital gangrene, venous thromboembolism, arterial thromboembolism, and prophylactic use of heparin should not be given in routinely. It can only be given in the perioperative periods. And it is also seen that in patients with DIC, there is decreased levels of antithrombin also. And heparins act basically with the help of antithrombins. So along with heparins, if you give antithrombin concentrates also, it increases the response. Also, there is something called as purpura fulminans, which is nothing but hereditary or acquired deficiency of protein C. In case of acquired deficiency, it is basically meningococcemia, which leads to protein C deficiency. In such patients, there is bleeding into the skin, which is the hemorrhagic necrosis of the skin, leading to called as purpura fulminans. In that, we can give protein C concentrate, 100 units per kg bolus, followed by 6 unit hourly, 6 hourly. I think 10 units per kg 6 hourly. It is not commonly available. And third thing is recombinant thrombomodulin. It has both anticoagulant and anti-inflammatory effects, and it is particularly useful for DIC associated with inflammatory diseases. But it is not commonly available, but there have been many articles which showed its use in Japan. So low molecular weight heparin in DIC, remember that it can only be given in life or limb threatening thromboembolic episodes when the bleeding is absent and when the platelet counts exceed 30,000 per millimeter cube. So the treatment based on pathophysiology is important to understand. So there has been a paradigm shift from treatment based on clinical and lab abnormalities to the treatment based on individual pathophysiology, as we have seen. So newer therapies in DIC are recombinant thrombomodulin, antithrombin concentrates, synthetic protease inhibitors, recombinant tissue factor pathway inhibitors, and recombinant human APCs like protein alpha. But it was withdrawn in 2019 and reintroduced in certain countries. So these are certain guidelines. Thank you.
Not much of questions, but you had a good presentation, Vaishnavi. Only your flawless and though you need to, I told you the in between teaser that you need to slide. It is a very huge topic, but slightly wherever you need to stop for giving more emphasis on a particular slide, you can do that. Okay. Second, your slides were very good. If you see the you spoke in everything pathophysiology very nicely. So this the pathophysiology which you discussed, it can be a short note in your upcoming exams. Okay. So those once it's the Apatkalin, those who are interested, please read the way she has mentioned, and you use, I think, on your hand, खुद आपने लिखा है वो, on the slides. That is commendable, and with diagrams also you have made. So she has made a lot of effort in putting, making the slides. I know many of the residents who have copied and downloaded from internet and pasted it in the slide and presented in the next morning. For God's sake, you'll be caught and you cannot be pardoned, right? So this is the kind of effort she has done. So give big round of applause to. But you have gone with a new model, of. And how did you do that?
iPad.
Huh?
iPad.
अच्छा iPad से किया तुमने?
Yes.
तो iPad में करके शेयर किया होगा तुमने? और pencil?
Apple Pencil.
हाँ, I know. Notes लिख रहे थे. अरे चारू ने भी काफी उसमें प्रेजेंटेशन में अपने यूज किए थे. ये लोग कर लेते. But pathophysiology was good, so that means in paper one, Vaishnavis will do very well. Yeah, paper one is all about anatomy and physiology, applied anatomy and physiology. So we make आ भी जाएगा. These are exam questions, ये आएगा. हम तो कह रहे हैं कि तुम्हें आएगा, पढ़ के आगे करो. है ना? बताने के लिए आंसर नहीं करेगा ना. ठीक है, these are must for pathophysiology. चलिए, okay, well done.